My story begins as a graduate student at Carnegie Mellon University. I was studying decision-making, combination of decision psychology and behavioral economics, and was diagnosed with myelodysplastic syndrome, a blood disorder that was going to kill me within about 10 to 12 years if I did not undergo a bone marrow transplant. But if I underwent the bone marrow transplant, I faced a risk of being cured, a chance of being cured of about 75%, and a chance that the transplant itself would kill me within 6 months to a year of about 20 to 25%. My health experiences drove home to me how omnipresent risk is in all of healthcare, especially from the patient standpoint. I'm never 10% anything, right? I either live, I die. And so it's that outcome that somebody has to live with, quite literally, that we're trying to communicate to people about. I'm a core faculty member in the Center for Bioethics and Social Sciences in Medicine, or CBSSM, which is a home for social scientists. People like me come with a variety of different types of backgrounds, but whose common thread is we're interested in using social science methods to look at healthcare delivery issues, health services research, et cetera. I think about the problem from the patient standpoint or from the on-the-ground clinician standpoint. How will that person intake that information? How will they make sense of it? And so I can have conversations with people where they go, well, they have to know this. And I say, yes, they do, but how? And work with them to make that happen. There's another piece of my work which is about storytelling. I research the power of narratives, the stories of other patients who have gone through similar experiences, as ways of helping patients understand this is how to make a decision, or this is a piece of information that you might need to consider, or even this is what it feels like to have a procedure happen. That lived experience is an incredibly powerful communication tool. What I hope my contribution will be is to change the conversation from being about, do we have the right numbers, to do we understand what they mean? Do the patients have any idea how to take the number that they're seeing on the online portal from their lab test results and know what to do with it, whether they need to change their medications, whether they need to eat differently? If we don't work on that human element, it doesn't matter how much data we have. It will all be for naught. If I pick up the phone and call somebody who I've never talked to before on the Michigan campus, who has some expertise that I think is interesting or relevant, I expect that that person is going to say, sure, let me talk to you. Let's meet for coffee. Let's engage, at least for a little while, to see what we have as common interests. And that willingness to go across disciplinary boundaries, department boundaries, school boundaries, institute boundaries is, I think, fundamental to what the University of Michigan is about. And it's what makes IHPI possible to exist. That's, I think, a critical difference, because that person-to-person contact, that hallway conversation where, hey, what are you working on? Oh, that's really interesting. Can I be part of that? That becomes the next grant and the next project and the next paper. 20 years from now, we're going to have tons of data available at our fingertips. Our patients will be more empowered than they are today, but they will also be more overwhelmed than they are today. And we will have to somehow help them through that process. I see IHPI as a centerpiece to that problem, because IHPI brings the clinicians, the people who are gathering the data, whether through clinical trials or otherwise, the practicing healthcare providers, and people like myself, social scientists or others who can guide the communication processes, together in one place so that we can recognize the problems, work on them together, and then potentially develop solutions together.